Hello everybody. In this lecture we are going to discuss about lupus erythematosus. Lupus erythematosus, also known as LE. It is not just a cosmetic deformity which can cause psychological upset due to disfigurement which can arise thereof, but at times it can be catastrophic and can damage various vital organs, leading to perpetuating organ dysfunction and or failure and even death. In the early era of development of medical sciences, the knowledge about LE was limited to weakness manifestation. But with the passage of time, the understanding of the disease has expanded logarithmically. Now we know what we see on the skin can really help us to understand what's happening inside the body. So this lupus erythematosus is a classical example of condition where skin can be a window to the underlying system. We had about knowing regarding the history about lupus. You know, the name lupus must have come by the destructive look which it produces on the face, the look which can be produced as something which is being gnawed by wolf or scratched by wolf, so the name lupus. It is possible that in the beginning it did not refer to a particular disease but rather to ulcerative injury with the destruction of tissue with the comparison of bite of hungry wolf. At that point of time, cutaneous tuberculosis was so very prevalent. So this term lupus is used in two different settings. One, lupus vulgaris, which is caused by Mycobacterium tuberculosis, and also in the setting of the connective tissue disorder, where we know it's known as lupus erythematosus. The real description behind the term lupus is rather by Peter Cazenave, who in 1851 published the unforgettable description, and if I may quote him, he said that in some circumstances lupus manifests itself at first as a violet rubefaction on this or that part of the face and mainly on the nose, which at the same time is rather swollen. Over many months, the color rises little by little, the surface becomes animated, a small ulcer forms, and on the top of it, a scab which then thickens and covers the ulcer, which becomes progressively deeper. Lastly, the skin may get thinner in imperceptible stages and adopt the appearance of a scar without there being tubercles or ulcer and without displaying worse injuries than a livid color. And from time to time, a light and barely perceptible feeling. These were the words which were being described by Cazenave, and it holds true even today. Lupus erythematosus is not just a disease, it's just like a syndrome which can have various clinical findings with different biochemical changes, some distinctive histopathological appearance, which can also have variation. We now know that cutaneous lupus erythematosus can be skin limited, or even it can be systemic. When the cutaneous lupus erythematosus is involved in the system, we call it systemic lupus erythematosus, in other words, SLE. We in this lecture will highlight on when to suspect a lupus, and when you are suspecting lupus, what history you must be taking in tune of the onset, progress, the systemic features, drugs, and some typical association, for example, uh, relation to sunlight, regarding smoking, and then what examination we are to make regarding the extent of the disease and which systems we are going to examine for. Also, we would be dealing with the investigation which we would be needing and how to manage lupus. Now, let's see this lady. We are seeing some erythema which is present over the face. And if you see, the nasolabial furrow is paired. Both the cheeks are involved, and you have to take it from me that they are not elevated. And you also have to take it from me that if you try to blanch the skin, it's not blanchable. That is to say, the erythema is fixed. So here we got a lady, we have got a fixed erythema on the malar area, which is pairing the nasolabial furrow, and it is assumed just like the wings of butterfly. And this typical manifestation is otherwise known as butterfly rash or a malar rash. Now look at this lady. Here we got lesions which are palpable, which are elevated, and you can see there are some large plaques and there are some small papules which have been covered with scales, some visible exfoliations visible over there. So essentially, if we have to coin a term, we would call it a papulosquamous disorder, which is occupying the sun exposed area. You can see the V area of the back is affected, and those which are being covered by the clothing are rather spared. So this is another form of manifestation in case of cutaneous lupus. Coming to another lesion, and here you will find the similarity in description which was done by Cazenave. Here we find a plaque which is well demarcated, which is surmounted by scales, and you have to take it from me that they are thick and they cannot be easily removed. They are adherent, and you can see the plaque is red, it's erythematous, and the margin is having some bluish hue. They are on the exposed parts of the body. So this disc-shaped erythematous plaque or discoid plaque is a typical manifestation in case of cutaneous lupus. Because of its appearance, It can also be termed as discoid lupus erythematosus or DLE. Coming to a rather more virulent form of the disease, the same DLE which is occupying the entire face, it has destroyed the hairs and is causing alopecia, and the scalp is just scarred. You can appreciate a DLE which was present on the chest, which is somewhat healed with depigmentation, and you can appreciate the bluish margin over there. This lady did not have a very good outcome. The skin lesions suggest that the DLE was so severe, it was on the face and below the clavicle, it was disseminated, it was generalized, and there is more chance of systemic involvement. Yes, there was systemic involvement and the lady succumbed to it, unfortunately. Now, please look at the palate. Can you appreciate some erosions over there? These erosions are painless. The lady is not going to come to you and say that, doctor, I am having some painful condition in my mouth. But when you are having that index of suspicion and you ask the patient to open the mouth and you look at the palate and you find the erosion, then you find, yes, this is a condition where you find palatal erosion which are painless. So this is another manifestation of SLE. Now look at the scalp. There are areas of hair loss and you can appreciate there is complete destruction of the hairs. So these are scarred. So this is a form of alopecia which you can find in case of lupus erythematosus. This is a form of scarring alopecia which can arise because of a DLE lesion which was occupying the scalp. And now look at this lady. Here you find this loss of hair. The loss of hair is present on the frontal aspect, but yes, the hair follicles are present. It's not a destructive variety of hair loss. This is a form of telogen effluvium when the patient starts losing hair at a rapid pace. This is a very rare manifestation in case of LE where the LE is involving the subcutis and the subcutaneous fat are lost, and on healing they have got those sunken areas. These sunken areas are the representation of the preceding inflammation which has occurred on the subcutaneous tissue. This is also a manifestation of cutaneous lupus, which is, or rather can be known as lupus profundus. Please have a look at the leg of the patient. You can find those black, charred, necrotic areas. So this is necrosis, which is occurring because of inflammation of the blood vessels supplying the skin. So it is essentially a vasculitis. You can appreciate some erythema occurring near the cuff, which are a form of purpura, also a manifestation of vasculitis. In case of lupus erythematosus, we might be getting vasculitis manifesting as purpura and to the florid extent of a vasculitic ulcer. Now coming to the epidemiology. Skin is one of the important manifestation in case of SLE patient, occurring in about 80% of cases, though the most common organ that is being involved in SLE are the joints. So rheumatologists are the most common discipline or most important discipline in medical science who deals with cutaneous lupus. Skin is important because they often are the presenting symptoms. In case of acute cutaneous lupus erythematosus, and what are they? I've shown you the picture of malar rash. So they are a form of acute cutaneous lupus erythematosus. If they are involving only the malar area, it's malar rash, and sometimes those erythema, those fixed erythema, can be occupying on the entire body. So that's generalized variety of acute cutaneous lupus erythematosus. It is found that 64% of the patient suffers from acute cutaneous lupus erythematosus. I've shown you the picture of DLE, where there was discoid lesion on the face, which was covered with thick adherent scales with bluish margin, which heals with depigmentation. They are a form of chronic cutaneous lupus erythematosus. They are not that common, but of course they are extremely pathognomonic. Coming to the age and sex distribution, it is not always remember to memorize those figures, but always remember that SLE is a connective tissue disorder. So this SLE, just like other connective tissue disorder, is more common in women. All connective tissue disorders, they manifest in the second decade, and SLE is no exceptions. The prevalence of SLE is found to be more in US and less in India. It can be because of less reporting. So don't have to remember this figure. Always remember SLE is a disease of female and is a disease of young adults. Pathogenesis of lupus is complex. There is a interplay of various factors which lead to the generation and formation of the lesion. The environment plays a very important role in its pathogenesis. Ultraviolet light, both the UVA and UVB, are the key mediator of etiologenesis. Apart from that, in some person, drugs which are slow acetylators are implicated. They are essentially the drug-induced lupus. There are hypotheses which states that EBV, smoking, and even some foodstuff may be implicated. But their role is controversial. Now we all are exposed to ultraviolet light. Not everyone develops the disease. That is essentially because of our genetic makeup. There are certain HLAs being identified which predisposes an individual to develop lupus. The HLA DR2 and DR3. Even complement C1q deficiency, some polymorphism in TNF alpha, some polymorphism in IL-6, IL-10, they also contribute to the pathogenesis of lupus. Coming to the hormonal milieu, high estrogen, low testosterone, high prolactin, increased hydroxylation of estrogen, they are also responsible, and this explains why women are more predisposed to develop the condition. When these factors they interplay among themselves, there is essentially an overactivity of the B cells. The overactive B cells have an influence on T cells as well as the cytokines. In the T cells, among the T cells, it's found that the helper T cells either are increased or remain the same, but the suppressor T cells are reduced in number. The cytotoxic T cells are reduced, and these T cells again activate the B cells. With some change in the cytokine profile, with the Th2 cytokines, the IL-6 and IL-10 becoming increased, and the Th1 cytokines, essentially interferon gamma, TNF alpha, IL-1, 2, 12, they are reduced. These changes in the immunological profile leads to the production of various antibodies, the anti-nuclear antibodies, which can be either anti-DS, anti-single-stranded, anti-Smith, anti-histones, anti-ribonucleoprotein, anti-Rho, La. The half-life of these antibodies are also increased, and they together can cause either a direct damage or a functional alteration of the organ or organ system. Even the immune complexes formed by these antibodies, they also damages the organ. Coming to, coming to the clinical manifestation of SLE, the most common manifestations are of course the non-specific one, fever, anorexia, and as I have told before, the rheumatological complaints are the commonest, followed by hematological manifestations, cutaneous manifestations, neurological, cardiovascular, renal, GI, and we can understand so many different organs can be involved in LE. And regarding the skin manifestations, I have discussed previously. To have an understanding of the different organs which are involved, if we go ahead with the classification system, we'll have an idea of that. Previously, the classification criteria proposed by the American College of Rheumatology was followed, but recently a new classification criteria has come up, which is the Systemic Lupus International Collaborating Clinics Classification Criteria, in short, the SLIC criteria. We shall have a discussion on the two form of classification criteria and how they give us an insight about the clinical manifestation, and would compare the two criteria head to head. Coming to the skin lesion, malar rash, photosensitivity and discoid rash, they are or they were the hallmark criteria proposed by ACR. I've shown you the picture of malar rash, which is fixed, or in other words, non-blanchable erythema, which is occupying the malar area, having a butterfly shaped rash which spears the nasolabial furrow, is one of the hallmark. Photosensitivity means that the skin lesions, they have got an unusual reaction to sunlight. which can be elicited by taking history, and of course the discoid lesion or DLE, which we have discussed before. In the slick criteria, the malar rash and photosensitivity are clubbed together, and it states that not only malar rash but any morbilliform rash which can involve any extent of the skin and which shows photosensitivity can be one of the criteria. In addition to malar rash, the new criteria has included the subacute cutaneous lupus. If you remember the picture of the lady who was having papilloscomus lesion on the back is a form of subacute cutaneous lupus erythematosus, and this entity was lacking in the previous ACR criteria. The slick criteria also states that we have to differentiate the generalized rash of lupus from dermatomyositis. But how? Just to give you a thumb rule, if the morbilliform rash occupies the knuckles, it's more towards dermatomyositis. And if the morbilliform rash spares the knuckle, it is more towards SLE. Now coming towards discoid rash, which in slick criteria is renamed as chronic cutaneous lupus because essentially DLE is a chronic cutaneous lupus. In addition to DLE, the newer criteria also includes the other form of chronic cutaneous lupus, which includes the hypertrophic variety, the lupus profundus, which I have shown you the picture of the man having sunken cheeks, the chilblain lupus, the DLE and lichen planus overlap. So we understand the slick criteria is more holistic than the previous one, and it includes all different manifestations of lupus. So if we recapitulate, the skin lesion in lupus can be a acute cutaneous lupus erythematosus, which can take the form of a malar rash, or the erythema can be generalized but sparing the knuckles. It can take the form of papilloscomus lesion, which is present on the sun exposed areas, which is the subacute cutaneous lupus erythematosus. It can be a discoid lesion with an erythematous plaque having thick adherent scales. Adherent because the hair follicles are being plugged by the scales, also known as follicular plugging in histology. And if we try to peel it off, and after peeling it off, if we keep the slides upside down, we can see the tacks of those keratin plug which is pointing upward, and it mimics the tacks of carpet. So the name carpet tack sign has evolved. In the new criteria, the non-scarring alopecia is also involved, and I have shown you the picture of a lady where the lady was having baldness involving the front, and few small hairs were visible. Those small stout hairs are otherwise known as lupus hairs. Now coming to the oral ulcers. Oral ulcers in SLE are painless. They are not noticed by the patients, but they are rather examined and found out by the physician. They can involve mostly the palate, but they can involve the buccal mucosa, tongue, nasal areas. Arthritis is one of the criteria which is being proposed by the ACR. In the new criteria, it has become more objective, like synovitis involving more than two joints or tenderness involving more than two joints is being classified as one of the criteria. Serositis in the form of pleuritis, pericarditis is an important feature. Pleurisy for more than one day, pleural effusion, they are included in the SLIC criteria. In ACR criteria, there are 11 criteria, and presence of any 4 criteria classifies the patient to be a patient of SLE. In case of SLIC criteria, there are 17 of them, of which any 4 may be present, but of which one of them has to be a clinical one and one the immunological. It has given the liberty that if biopsy proven lupus nephritis is found, then it can be considered as a pathognomonic feature of SLE. So in this slide we find that both the criteria are almost the same, excepting the non-scarring alopecia, which is typically found or typically included in the SLIC, which was absent in the ACR. If we look at the other criteria, the renal involvement, which is characterized by proteinuria or cellular cast, neurological involvement, which can be either seizure or psychosis, which was proposed in the ACR, and now the SLIC criteria has expanded itself to involve even mononeuritis multiplex, myelitis, even vasculitis, and even acute convulsional states. Hematological criteria are all penias. It's either anemia, leukopenia, lymphopenia, thrombocytopenia. If you remember the values, leukopenia less than 4000 per cubic millimeter, lymphopenia should be less than 1000, and the platelet should be less than 1 lakh. And we have known that among these 3 criteria, renal, neurological and hematological, the neurological criteria has shown some expansion in the SLIC. Coming to the immunological criteria, ANA has to be above the lab range. The various anti-nuclear antibodies, which can be either anti-DS, anti-Smith, anti-phospholipid, are important parameters. In the ARA, all these different antibodies were clubbed together, and in the new criteria, they are given separate weightage. Here in SLIC criteria, one important or two important new additions are there. One is low complement, which can be low C3, C4 or low CH50, and addition of direct Combs test in the absence of hemolytic anemia is a factor for consideration. So these are all the clinical manifestations which encompasses the diagnosis of lupus erythematosus or systemic lupus erythematosus SLE. Coming to the skin lesions in case of cutaneous lupus. We have discussed before the skin lesions in cutaneous lupus can be categorized into acute, subacute and chronic. These skin lesions are those where on histology we find some typical features which we shall discuss later. Coming to the acute form, it can be localized on the face, on the malar area to be very precise, and is known as malar rash. The malar rash is a fixed erythema which occupies the malar area and spares the nasolabial furrow. Of course, when you are considering a malar rash, you have to keep into consideration seborrheic dermatitis, rosacea, any allergic contact dermatitis which is occurring on face. To differentiate between them and malar rash, important pointers are the fixed nature of the erythema and the nasolabial furrow. Such erythema or morbidiform rash can occupy the body when it is known as a generalized form of acute cutaneous lupus erythematosus. As I have discussed before, the generalized form of the acute cutaneous lupus erythematosus will spare the knuckles. In contrast to dermatomyositis, where similar confluent violaceous macular edema will involve the knuckles. Coming to the subacute form, it can manifest as papulosquamous lesion, which is more common, and we have seen the picture of such lesion on the sun exposed area. Sometimes the lesion may be annular and they are pretty rare. The chronic cutaneous lupus erythematosus is manifested classically by discoid lupus erythematosus, the picture of which we have seen before. It can be localized on the face, or sometimes they can occupy both above and below the clavicle when it is known as generalized, and the chances of progression to SLE is more in case of generalized ALE than localized. Other rare forms of chronic cutaneous lupus erythematosus do exist, which include the hypertrophic variety, where it manifests as varicose growth. Sometimes the paniculus or the subcutis may be involved when it is known as ALE paniculitis, otherwise known as ALE profundus. Sometimes it can involve the mucosa, which is known as mucosal ALE. Sometimes ALE can manifest as a tumid or juicy lesion without any scales on top of it, which is ALE tumidus. Chilblain ALE or perniotic ALE are typical features which are manifested as a chilblain lesion with exposure to cold. Sometimes DLE and lichen planus can overlap. Apart from these ALE specific skin lesion where a typical histological changes are found, in case of lupus, there are various other form of a lesion where histology won't reveal the typical form, but they are very commonly associated with lupus. One of the most important such lesion is vasculitis, which can be leukocytoclastic vasculitis manifested as palpebral purpura. arterial vasculitis, sometimes vasculitic ulcer that we have seen in the previous picture. Sometimes polyarthritis like nodosa may be present, vasculopathy, periungual telangiectasia, livedoid reticularis, thrombophlebitis, Raynaud's phenomena, erythromelalgia are the other cutaneous vascular lesions. Hair changes are common, and now the hair changes are also included in the SLAC criteria. Telogen effluvium that we have seen in the picture can be present along with lupus hair, which are short stout hair present on the frontal aspect, and even alopecia areata. Sclerodactyly, which is more suggestive of systemic sclerosis, may also be present in lupus, along with rheumatoid nodules, calcinosis cutis, and bullous lesions, which are not allele-specific. Urticaria, mucinosis, cutis laxa, acanthosis nigricans, erythema multiforme, leg ulcers, lichen planus may also be found. When lupus erythematosus is associated with erythema multiforme, we have got a specific name for it. We call it Rowell's syndrome. Coming to the diagnosis. Diagnosis is essentially clinical, but at times we need help of histopathology and even direct immunofluorescence. Prognosis, of course, is determined by the systemic involvement. Coming to the histology, the list is huge, but we have to remember that lichenoid tissue reaction or interface dermatitis is the hallmark. And what is that? Let's see a picture. If you see from above, we find that the stratum corneum, which is the uppermost dead layer of epidermis, is thickened, and it is known as hyperkeratosis. The stratum corneum, they invaginate itself into the hair follicles and plugging the hair follicles, and histologically we find that typical follicular plugging. What is most conspicuous in case of lupus histology is lichenoid infiltrate. What is that? It's the basal cell vacuolation. The basal cell of the epidermis, they undergo the vacuolar degeneration, and with that the melanin which are present in the basal layers, they drop to the dermis, which is otherwise known as melanin incontinence, and there is mononuclear infiltrate in the dermoepidermal junction. Not only the dermoepidermal junction, even the appendages and around the blood vessels, they are present. So this is the typical histology in case of lupus erythematosus, on which Gilliam has classified the allele lesions into allele specific, where this typical histology are present, and allele non-specific, where this typical histology is not found. Coming to the direct immunofluorescence, immunoglobulin A, IgA, IgG, and IgM, they can be deposited along the dermoepidermal junction in a continuous band, and this band is otherwise known as lupus band. This lupus band is found both in the lesion or outside the lesion. Typically, if you found a lupus band in the sun protected area, that is very much a hallmark of the disease. So skin biopsies are usually taken from the buttocks to see the presence of lupus band out there. Coming to the very important aspect of treatment in case of lupus erythematosus. Most important of it, the component of treatment is photoprotection, avoidance from sunlight. Depending on the occupation, on the socio-cultural parameters, different form of protective measures are to be implemented. Covering the skin with clothing as far as possible is the best way out. The body parts which cannot be covered with the clothing, they can be smeared with sunscreen of SPF of at least 15 or more. Sometimes who work outdoors, the farmers, if they wear some wide brimmed hat, that's beneficial. So one important message should go while counseling is that sun exposure is to be avoided. Not only the sun exposure flares the skin lesion, but it flares the systemic involvement too. Cessation of smoking is very important because one of the important drug in the management of lupus is hydroxychloroquine, and those who are smokers, the effect of hydroxychloroquine is less in them. Coming to specific pharmacotherapy, antimalarials, the hydroxychloroquine is very important and plays a pivotal role in the management of cutaneous lupus. Of course, one has to remember that hydroxychloroquine is toxic to the retina. So before starting hydroxychloroquine, one must have a retinal check done, and then it has to be followed up. Immunosuppressants are given where there is some organ threatening condition or it's life threatening. Various immunosuppressives can be chosen according to the general condition of the patient. It can be glucocorticoid, it can be cyclophosphamide, it can be mycophenolate mofetil, of which of course mycophenolate mofetil is the safest. Other agents are like dapsone, thalidomide, acitretins, and even nowadays biologicals have come, they can be used. But the treatment has to be tailor-made according to the severity of the disease in a particular person, and of course the purchasing ability of a person. For cutaneous lupus, topical corticosteroid has to be used. This topical corticosteroid has to be a high potent one. We very well know that high potent corticosteroid runs the risk of giving rise to atrophy of the skin and disfigurement. But what Du Bois has told in his famous book on lupus, that the disfigurement produced by lupus is far more than what can be produced by steroids. So controlling the disease is very important. So control the disease with a potent corticosteroid and stop it as soon as you find that the disease has come to a halt. In some case, they don't respond to a topical one, then one has to go for intralesional corticosteroids too. So that's it from lupus erythematosus. Thank you everybody.